Samir, if you're ready to start, it's 8 o'clock now.
We can wait for 2 minutes and we will start.
Okay.
Pavan?
Okay, sir. Ready to go. Dear friends, very good evening and welcome to the one more episode of the Association of the Adolescent and Childcare in India International Forum webinar series. Before we start, if a few people may not know what the AACCI is, so for that, I just go for a very short introduction of the AACCI. AACCI is the Association of the Adolescent and Childcare in India, which is having a mission in holistic health in the children and adolescent and young adults, promotion of the healthy lifestyle and prevention of the lifestyle associated disease through life skill approach. We work through the mainly two pillars, that is the parents and teachers, of course, along with the children. And now we had also added the one more pillar, that is the grandparents since 2020. We having a group of the doctors that include the pediatricians, physicians, and all other specialists and the mental health professionals. We also have the volunteers who are the stakeholders of the child and adolescent health, which include the parents, teachers, educationalists, lawyers, sports, physiotherapists, and research scientists. We mainly do the urban-based work with the parents, teachers, and students in the school and college, and when mainly depends on the our urban-based population. But now also recently we start the tribal children project also. We having a center throughout the India that will be running under the direction of the our board of the director, that include the our honorary chairman Dr. Yashwant Bhave sir, executive director Dr. Swati Bhave madam, the our honorary secretary Dr. Sarmila Lele, myself Dr. Samir Sai is the national coordinator, and along with our chairperson of the internal ethical committee and the our research protocol. We having a different forum, that is the youth forum, parents forum, teacher forum, and grand forum, and that will be also headed by the specialists in the field. We have almost more than 250 volunteers across the India, and now we also expanded ourselves in the international forum also with the able leadership of the Dr. Grandes and the of course the Dr. Neil Soren. We have engaged our enough social media presence also on the Facebook, WhatsApp, Instagram, and Twitter. We do this so many international activity on regular basis and every year. That includes this international forum activity along with the international adolescent health week celebration with the help of our own volunteers. And these are the series of the international webinar series that we have started since last year and able to conduct so many webinars with the help of our international faculty with a very important topic related with the child health. Last webinar was on this pediatric sleep problem, was very well attended and appreciated. Today, we have got two eminent speakers again from the Michigan University. That one is the Megan Burke. She is the development and behavioral pediatrician at Michigan Medicine. She has attended medical school at the American University of the Caribbean, completed her pediatric residency in the Broson Children's Hospital, and developmental behavioral pediatric fellowship at the University of Michigan. Her current work include the autism spectrum disorder evaluation, elimination disorder evaluation, and management of the rural outreach. At the same time, we also having our own eminent speaker. She has already contributed in a few of our webinar series that include Dr. Barbara Feld. She is professor in the Division of the Development and Behavioral Pediatrics and program director of the fellowship training program at University of Michigan. She went to a medical school at the Wade State University, Detroit, and completed pediatric residency at Johns Hopkins Hospital, Baltimore, and having a fellowship at Rainbow Babies and Children Hospital, Case Western Reserve University. She is having a practice since 37 years with a clinical interest in the attention deficit hyperactivity disorder, pediatric sleep disorder, and elimination disorder. She has definitely a keen research interest and almost 71 publications and in peer-reviewed journal. With the short introduction of the our today's eminent speaker, I directly hand over the mic to both of the speakers to speak on our today's topic, that is the pediatric elimination disorder. Madam, mic is yours. Thank you.
Thank you. Let me start sharing my screen and we can get going with our presentation today. Are you all seeing our PowerPoint? Okay,
Yes.
perfect. All right, so thank you for joining us to talk about toilet training and constipation in kids. We have no conflicts to disclose. And our goals for today will be to understand toilet training factors, understand the pathophysiology of constipation and stool incontinence, consider different toilet training challenges in children, and particularly with neurodevelopmental disorders, understand and know how to evaluate and treat functional constipation, and make some behavioral connections and resources at the end. And I'll turn it over to Dr. Felt to start with toilet training factors.
Terrific. Next slide. So I don't need to tell anyone online about the variability in toilet training dependent on country and culture and cultures within countries. Some of the data I present here represent studies that are in different cultures, like a study in Switzerland looking at when did children attain continence. And so in the 1950s and 60s, looking at longitudinal cohorts, stool continence was achieved for 97% of children by age 3, daytime urine continence for 90% by age 4 and nearly 100% by age 6, and nighttime continence attained by for 90 to 94% by 6 years of age. We know that many cultures, and I'll talk about the U.S. Culture earlier on, train in infancy. And looking at some information about India, I think some cultures within your country do train in infancy, which requires really particularly attentive parents to the child's cues. In Belgium, there was an interesting study in 2000 that asked people to report on when they trained their own children. And they broke it down by whether the respondent was more than 60 years of age, 40 to 60 years of age, or 20 to 40 years of age, and found that over time, this was representative of what we see in the US, that the age at toilet training got later, such that those who were the eldest in this respondent group had trained their kids less than 18 months at 88%, but those in, say, the early 1980s to 90s, only 22% had trained under 18 months. Next slide. So in the US, we know that in the early 20th century and in the 19th century, infancy training was really common. But by the 1930s, that began to change due to some concerns that early infant training led to a greater risk of regression later on. And then in the 1940s, a general pediatrician who wrote on many child care topics, Benjamin Spock, really suggested strongly that parents begin to watch for their child's readiness cues. And Barry Brazelton picked that idea up in about 1962 when he had a seminal paper on child-oriented training. And then psychologists Azarin and Fox had a book, Toilet Training in One Day, that really also looked at the child readiness, but took a more parent-oriented approach. Brazelton had suggested that watching for child's readiness cues could be the best way to go. And in fact, the American Academy of Pediatrics really supports that view. The Azarin and Fox method asks parents to supply more fluids, do regular sit times, give positive reinforcement and overcorrection for errors in toileting, which was very successful for individuals with intellectual disabilities, which was their first cohort, and then later demonstrated to also be successful in many children. But these two approaches have not been looked at simultaneously, and so we don't really know which one would be best. Next slide. So when are children ready to be toilet trained? There was a 2002 study in Milwaukee, Wisconsin, in a primarily Caucasian population that looked over time, surveying the parents of 15 to 42-month-old children in 4 pediatric practices. And training status was asked with weekly surveys over the course of 12 to 16 months. There were about 126 girls and 141 boys, and again, the majority were Caucasian. The red arrow is the median age for when girls or boys started staying dry during the day. And the green arrow shows the median age for when boys or girls entered the bathroom on their own to have a BM. And as you can see, most children in this cohort began to show readiness in general for skills after about their 2nd birthday, and that girls were a little bit ahead of boys in their attainment of these toilet readiness skills. Next slide. In general, though, a sequence was noted that is helpful to think about, that while these skills may differ a little bit by gender, most show BM control at night, then during the day, then urine control during the day, and then at night. Next slide. So what are the sort of readiness skills or prerequisites for children in a child-oriented approach to show that can kind of tell pediatricians and parents that the child's ready to toilet train? The ability to get to the toilet and be stable when sitting on the toilet, it can be a factor. And demonstration that they are remaining dry for several hours is important. That the child can have the motor ability, fine motor and gross motor, to get their clothing up and down, and language ability to understand the direction to get to the toilet, and maybe expressive ability to let their parent know that they need to go, rather than the parent needing to look for those subtle cues as is necessary for infant training. It's also helpful if the child shows interest and wants to please and is cooperative. Independence is actually a great factor because the child really wants to have success in this area. But being very oppositional in their independence might be a negative in the process. Next slide. But it's important to really think about toilet training as a teaching event, similar to learning to read and doing other things in life, and beginning to look for the opportunities and to praise the progress, whatever that is. And so getting started can be steps to involve the child. There are lots of books in our culture. I'm interested to hear in your culture whether there are books on toilet training to get the child interested in this process. In our culture, oftentimes, unfortunately, kids are living across different home settings, perhaps due to a divorce or one parent family who's really supported nicely, but by grandparents, but it involves another setting. And so having consistent expectations across settings can really help the child flourish and be successful with what they're being asked to do. Wearing loose clothing, having the potty chair, or being sort of near the bathroom is a benefit. And making the connection of what is this for? Sometimes demonstration of what's been produced and getting that into the toilet and demonstrating that to the child, or demonstrating as a model, as a parent model of what you're doing, and having the potty chair in a similar location. It's really helpful to praise whatever cooperation the child is giving. They may not be successful, similar to reading, lots of mistakes at the beginning, but to praise the effort is really important. Next slide. And collecting data is really helpful. And so around stool production in particular, there are times of day when people tend to go in the morning after meals, and collecting that data for your child or your parent's child can help define when good opportunities to direct them to the toilet would be. And if things aren't going well, take a break. Maybe the child's not quite ready, or it's not a place to increase frustration. That won't help the progress. Next slide. So these are the anticipatory guidance that the American Academy of Pediatrics provides by visit age, readiness signs to look for. But it's also important to take a full view of the context the child's in, and whether there are any expectations for things that could disrupt the progress of toilet training and take away from a more positive teaching approach. Are there pressures to do this from other family members when the parent really knows the child's not quite ready? Are they expecting another child to be born? Do they expect to move? Or will there be other disruptions that will make it a little harder for everybody to be as consistent and positive as possible? Next slide. So it's interesting, there was a study looking at the course of toilet training in the early 2000s. Children 17 to 19 months of age were enrolled and were followed by phone. The parents were followed by phone interviews every 2 to 3 months until training was completed. And what they found was that earlier initiation of training was associated with an earlier completion, but it took longer. So on the y-axis is the duration of intensive training. That's where toilet sits at least 3 times a day were implemented. What age did that start? I'm sorry, how long did that occur for? And then age of start is on the x-axis. And so you can see that it takes longer of that intensive training approach at younger ages. And after about 2 years to 27 months of age, it kind of settles into a nice curve. Next slide. So toileting resistance can be common and sometimes related to the expectations of the parent being not quite appropriate for the developmental readiness of the child, or perhaps there are some developmental delays that were not recognized previously. Maybe the child is less adaptable and flexible than their sibling on following parent directions. The biggest problem we see here, though, is what Dr. Burke's going to be talking about today, and that is constipation that can unfortunately create some negative experiences around toilet training. So that's really helpful to watch out for in this process. And other things like rashes at the perianal area and abdominal cramping at stool passage, etc. Next slide. So kids with neurodevelopmental disabilities will have a different course, but they may go along the same steps just later than neuronormative children. So using parent-oriented approaches like the Azar and Fox method, where it's a little more structured and you provide more opportunities for pee output, etc., by increasing fluids, and using that data collection method to get a handle on when are those stools produced so that a toileting scheduled sit can occur around that time. Avoiding constipation, and constipation is a lot more common in kids with neurodevelopmental disabilities, is really helpful. I'll show you some picture icons in a minute. Next slide. We had a wonderful nurse practitioner here in child psychiatry who wrote a book on called The Potty Journey on toilet training for kids with intellectual disabilities and autism. And it is very similar to how you all are going to be approaching toilet training, but again, with a lot of data taken from the child's progress, reinforcement of positive sort of steps toward toilet training, and being quite aware of the developmental status of the child so that the expectations are in line and progress can be supported. Next slide. So these are little icons that can help support the sort of the verbal prompts that are given. If a picture schedule is also there for the child to have another modality to understand what are they supposed to do in this process. Next slide. And I know in some areas of India, just kind of looking up in the weeks here before the talk, that use of a toilet may not be as common across all families, but the same idea, whether you're squatting or sitting, is true, that having your knees a little higher than your hips and a footstool, if it may be needed, especially for young kids and the height of the toilet, in order to achieve that correct position to really effectively expel stool. Next slide. A really, really important thing to remember around disorders of elimination, particularly in the area of constipation and soiling accidents, is that having a mental health issue is really common. While the general population may have psychological or behavioral concerns, 10 to 15%, it's much higher, magnitudes higher for kids with fecal incontinence, for instance. It doesn't surprise anyone that having ADHD might put a person at risk for not paying attention to their body or to hear, sort of sense the cues that they have to get in to use the toilet, or that they stay long enough at the toilet to get the job done when they're there. We also see in our clinics children with anxiety, which can really interfere with the progress of toileting. We also know that kids with fecal incontinence, so soiling accidents, are not only more likely to be bullied, but are more likely to be a bully. And so being aware of these factors might allow you to also treat and manage these other factors that may help the progress in toilet training or help the progress in management of constipation. Next slide. So here at University of Michigan, we're really fortunate to have a number of providers who are interested in elimination issues and come together around really complex cases, oftentimes that start with a colorectal malformation, surgery, or maybe it's really bad constipation that gets them in. But they may have co-occurring urinary disorder, need some surgical intervention, benefit from physical therapy. And this combined clinic we have about monthly to help address the needs for these complex kids, to try to deliver recommendations that are uniform across these practices and help kids do better. I'll turn it back to Dr. Burke.
Thank you. So now we'll pivot and talk a little bit about constipation and fecal incontinence. So encoparesis or fecal incontinence is an elimination disorder. It's defined in the DSM-5 as repeated stool passage into places that are inappropriate, so not where we need stool to go. It happens at least once a month for at least 3 months in a child who is either chronologically or developmentally 4 years or older. And it shouldn't be explained by any other like medication or medical factor other than constipation. And you can specify, does this fecal incontinence happen with or without constipation? Constipation is so common, and estimates are that it's about 30% of children and up to a third of adults also suffer from constipation, though we don't totally know exact numbers because not everybody seeks medical care when they're constipated, and so it could be much higher than that. It can be very costly to both the families and like medically for the workup constipation, and can really impact quality of life. And we see it kind of across the globe that it's a very common issue. While constipation is common, fecal incontinence is a little less so. It's about 3 to 4% of preschool-age kids and 1 to 2% of school-age children. And there are certain factors that can put kids at risk. Things like discomfort or developmental differences, genetics, and any diet or routine factors. We see the age of onset can start before 1 year of age in about a quarter of children. Most commonly, the onset is between 2 and 4 and can even happen after 5 years of age. And our diagnostic criteria, we use the Burke criteria for functional constipation. And this is in children who are 4 or older, need at least 2 or more of the following criteria to meet the diagnosis of functional constipation. You need 2 or fewer stools in a toilet per week, 1 or more episode of fecal incontinence a week, a history of stool retention or withholding of their stools, a history of hard or painful stool movements. They may have a large stool mass in the rectum, which we can see on physical or on x-ray, and a history of large stools that can clog a toilet. Thinking about the pathophysiology of constipation, we think back to like, what is the main job of the colon? It takes liquid stool from the small intestine and as that stool moves through, turns it into formed stool by reabsorbing water. The transit time through the large intestine is 30 to 45 hours, and the longer the stool is in there, the more water is reabsorbed and the more solid the stool can be. The stool goes from the large intestine into the rectum through an involuntary internal sphincter that relaxes and allows stool to enter. And the external anal sphincter is voluntary and contracts to hold the stool in or can be relaxed to let the stool out. As children may pass a stool or withhold their stools, the stool stays in there longer and more water is absorbed, and it can be big and hard. And then when it comes out and passes, it can be really painful. And children are smart. They want to avoid things that are painful, and so they learn quickly that, or make the association quickly, that pooping is pain, and then want to not poop again. So we'll withhold their stool, keep stool in there longer and longer, it gets bigger and harder, and then again, when it's passed, causes pain, and this is a vicious cycle that can repeat and get worse and worse. And as stool is held in the rectum and more stool builds up, it can create physiologic changes to the nerve function and the muscle function in the area. As the muscles are stretched, just like any muscle that's overstretched, it can be weakened, and so it is not as efficient at its job. So when it's supposed to be contracting and evacuating all the stool, it's weaker and may only get some out, which causes more buildup over time. The other thing that may happen is that the threshold for the nerve sensation to send a message to your brain letting you know that there is material there that needs to be let out, it kind of like takes more and more stool to trigger that mechanism and send that message. And so it allows more and more stool to be built up without the child actually knowing. This can lead to large, hard stools that are there and more liquid stool kind of coming through that sneaks around and leaks out into liquid fecal accidents that the child may not know about. Over time, the child can be accommodate to the smell and also the sensation of that stool on their skin, and truly may not know that they've had an accident unless they're alerted or see it when they go to the bathroom later. There's a number of things that can predispose a child to fecal incontinence, constipation being an important one. And we discussed the discomfort and painful stool passage. Stool impaction can lead to that leakage of stool. And then there also may be anatomic, metabolic, or neuromuscular complications that we can see. There are also medication side effects that may impact both gut motility, leading to constipation, which can lead to fecal incontinence, or may move things along quicker that may cause more liquid accidents. Other things we consider would be developmental delays or intellectual disability. Like Dr. Felt had mentioned, ADHD, oppositional behavior, autism, and anxiety we see very commonly, and less commonly, neglect or abuse can contribute to fecal incontinent behaviors. But overall, we usually do not see other significant psychiatric problems, and like volitional or willful stooling in places that are not the toilet is pretty rare. When we think of evaluating, we go through a history starting early at birth. Did they pass their meconium or that black sticky stool within 2 days of birth? And if yes, great. And if no, then we think about Hirschsprung's disease and can work that up further. We want to see what was stool pattern like in infancy and toddlerhood, particularly around changing from breast milk or formula to solid foods, and whenever toilet training started, how did that go? And we want to know now, what is stooling pattern like? How often is the child stooling and where? And we want to know how big the stool is and the consistency of the stool. And for the consistency, we often reference the Bristol stool chart as a tool to keep it really well defined as far as like how liquid or hard is the stool. We want to know family history, social history, and past medical history that can give us clues to other contributing medical factors or family like genetic factors. and want to know about any past evaluations that we, either behavioral or medical, and other specialists involved in their care. We look in their physical exam about growth, vital signs, abdominal exam, and we want to look at their back and spine for any signs of spinal dysraphism, look at their anus for anal placement and anal reflex. And digital rectal exam is often not necessary in children, and only do so if we can't kind of determine stool burden other ways. And we also do a neuro exam, checking reflexes and tone and strength. As we move through our history and physical, we think about what other tools can we use to further evaluate. So we may consider an abdominal x-ray to evaluate stool burden, or things like thyroid or celiac studies to determine if these are medical factors at play for the child. In thinking of a differential, we think about a couple of different kind of groupings. GI or metabolic factors may present similarly or contribute to constipation or fecal incontinence. We think about anatomic factors like an anteriorly displaced anus, anal stenosis, or any fissures, anal fissures that could be causing pain, or neuromuscular differences like abdominal muscle abnormality or spinal cord differences, tethered cord, that might be impacting the child's ability to stool. Here's an example of an abdominal x-ray. When I look at an x-ray, this is an AP film, so shooting from the front. So this is the right side, this is the left side. And we can look the course of the colon to see where is stool, going up, over, down, and then out through the rectum. And we see that in this area, there's a large stool burden. This more like higher density is like a large stool impaction that would be impacting the child's ability to stool and may lead to fecal incontinence. In managing fecal incontinence and functional constipation, we spend a lot of time on education, and it's so important to spend the time doing this because this is a chronic condition that families need to understand and commit to the consistency in medication management and behavioral interventions for this. And so it's worthwhile to kind of share that. We go over kind of everything we talked about with the family, common conditions, risk factors, the changes that happen in the gut, and really importantly, that it's no one's fault that this is happening, not the child's and not the parents. And that's important to keep as a theme throughout this. We also talk about the chronic nature of it, that this is not something that happened overnight, and this is not something that will resolve overnight. And it's important to set that timeline for families. It's once the diagnosis is made and we get started on medical management, once a child is stooling regularly and predictably, we can start working on behaviors if there are any. And so it's important still with the medical management and behavior management to stay positive and set realistic goals. If a child's not stooling where we need them to and is maybe like afraid to do that, and only maybe they're hiding in a certain spot and that's the only place they're stool, our first step is not to be having them stool right in that spot. It's to get them a lot more comfortable moving slowly, having small steps towards a goal that are realistic and that are achievable. Like Dr. Felt had mentioned, scheduled toilet sits are really helpful, and collecting data can help us place these toilet sits more strategically. And so, so we have a higher chance at success during the toilet sit timing. And then collecting data to help us understand the patterns and work smarter, and optimizing diet and fluid intake are all helpful. For parents, it's worth noting that this is frustrating, time-consuming, and oftentimes stressful for both the child and the parent. But it's so important for the messaging around toileting to be positive. And if parents can't stay positive, because it can be hard sometimes, to stay neutral at least. There was a study looking at like the child's self-efficacy. If they believe that they can do it, does that impact outcomes of functional constipation management? And they saw that after each doctor visit, all kids had like a little bump up in self-efficacy. And the ones who kept that and felt that they could succeed between visits were the ones who had better outcomes. And the ones who dipped down and had a decrease in self-efficacy between visits had longer treatment periods and had longer outcomes. And so the work that parents put in at home about messaging, about keeping things positive and encouraging is important and can truly shorten the treatment length. It's also important to highlight that backups and stool buildups and needing cleanouts is a common thing in treatment of constipation and is not a sign of failure or that we're taking steps backwards. It's just part of the treatment and treatment timeline. And so you can expect to do cleanouts. And when it happens, we do it and then we start fresh and make adjustments. And that's just part of the treatment process. The other thing is that consistency is key. If we are sticking to a behavior plan, then we stick to that thing and we keep it going and are consistent with it. If we're at a good spot with medication and laxative treatment and the child's stooling very regularly, then that is awesome. And that does not mean we stop medicines. That means you continue it going, and then we'll work together to determine when we can wean. For cleanouts, we have some cleanout regimens here. We use typically high-dose Miralax or magnesium citrate as in high doses to kind of flush all of the stool out orally. If a child cannot tolerate oral medications or if they have a fecal impaction that won't pass when being flushed from the top, then we can use enemas, a saline enema or mineral oil. And the goal is to continue the clean out until the stool output looks like tea-colored water. And that tells us that there's not any stool left or very little stool left and that the child is clear and we can start their daily regimen. You may consider a follow-up exam or an x-ray to see how much stool burden is left after a clean out. And some kids, if they can't tolerate a clean out outpatient, then they may need to be admitted to the hospital to get the stool burden out. We have here our maintenance medications. We use osmotic laxative to keep things mushy or like a musher, and then stimulant laxative to keep things moving. And that works at the muscle level to help kind of give that strength and efficacy back to the muscles. Again, sometimes suppositories or enemas are necessary, and we listed some that we use here. And that Thompson link is the NASPGHAN functional constipation guidelines that help guide our management and treatment. Course and recovery, the sooner kids are diagnosed and management starts, the sooner outcomes are improving. And so that is important to remember and start treatment when we start seeing signs. And behavioral interventions are more effective, or with medicine is more effective than just medication alone. Recovery rates, they looked at some studies to see that like 30 to 50% of kids had recovery at 1 year and 50 to 60% after 5 years. And that relapses are common. And so you may have to restart as soon as you start seeing any sort of symptoms of return. Here I put in some links for just like different social stories and potty training printable charts and a data collection stooling journal for parents that are all free. That might be a nice starting point for resources to use. And we'll end there. We'll take questions at this time. Thanks so much for listening.
Samir, are you there that you can moderate the question and answer session? If not, I'll go ahead and ask the first question. First of all, thank you so much for that presentation. I was wondering for many of our colleagues on the line, from the Indian perspective, how does one handle toilet training in a child in the context of multiple caregivers, joint family situations. Sometimes there could be circumstances where you have multi-generational families with different philosophies towards toileting. So grandparents might be a primary caregiver while parents are at work, and then weekends, maybe everybody's at home, etc. What sort of guidance do you give where there might be some different perspectives based on generational philosophies? Because you all had shown earlier that over time, different cohorts of ages of caregivers have changed philosophies. But if you have them all together in the same household, what's some of the recommendations that can be given? Thank you.
Dr. Suarez, is that to me or to the group of pediatricians?
No, to both of you, please. Yeah, just some thoughts that you might have if you come across that.
I know that I'll just state briefly that this is really a common scenario. Sometimes the multi-generations will be in the home here, as well as it sounds like that might be a bit more common in India. But it can be really tricky for a new parent. Maybe it's their first child, and their confidence in what's right might be, it's hard to get your footing sometimes as a new parent. And so the pressure on them to meet the expectations, not only that the pediatrician is saying around an appropriate developmental time, and then what their mother-in-law, let's say, is telling them is the only right way to go. And I think what I've tried to do is to get the voices in the room in my room so that we can all talk together and that the other family members can hear my perspective and help to support a common pathway that everyone is comfortable with. Maybe it's not exactly what I would have told a parent of a child who doesn't have this multi-generational kind of ghosts in the room, but at least everybody to try to get everybody on the same page, because I think showing honor and respect to the older family members is important, and there's nothing to be gained by disrespecting that person's knowledge and effort and support for the family. That they are a voice for the parent, I think, is a positive that we really want to take advantage of. But I do think communication is key, and that if another family member is way off track, that I have the opportunity to hear a little bit more about their perspective and help find the common pathway that the parent can then use.
Thank you for that. There's a question in the chat. How can we help an autistic child potty train?
Yeah, that's really a big set of the children that come our way, I would say, and is in part related to their developmental level. And so kids with autism, with on the more severe end of intellectual disability, their progress in toilet training may be different than a child who's presenting with symptoms of autism and have rigidity that may influence their flexibility to go along with parental direction and such. But my developmental expectations may be more neuronormative than otherwise. And so taking being watchful for their motoric and their language abilities would be similar to training a neuronormative child, but it might be that the structure and routine, maybe taking advantage of getting the routine in place and then the child latching onto that a little bit more strongly due to their inflexibility related to autism. I'd like to hear Dr. Burke's comments too on this.
Yeah, I think that I agree with everything that Dr. Felt had said, and I think what I will add is that like a lot of the children that we see who have autism, there's a sensory component to the stooling that is often distressing or can contribute to withholding of stools with like an abrupt change of location or setting. And so I think that taking a stepwise approach towards moving towards where we want them to be stooling, like a toilet, is important to be taking just small steps towards that. And then also managing like fairly aggressively their constipation and withholding behaviors to make sure that it's as pleasant sensory-wise as it can be, is so important in this process as well.
I agree. And I would add the co-occurrence of anxiety disorders and ADHD, very common for individuals with autism. And so looking for that with a heightened attitude and managing that can facilitate the toilet training process as well. But the course may need to be a little bit slower and again, really attending to developmental readiness factors.
Thank you. Please, yes, go ahead. Ask your question. Yes.
What is the long-term outcome of the delayed development of the incontinence or the late teleton? Is there any studies there for that? Ultimately, developmental bowel bladder disturbances or regarding that correlation something?
I'm wondering, Dr. Soares, could you repeat the question?
Yeah. So what is the long-term outcomes in terms of delayed acquisition of skills? Like, have there been any studies that show that people who do not achieve, toileting, either because of their baseline conditions or the fact that it has been challenging over time, like what sort of things do you see as they get older? I know at least in school-age children, this can be a source of great degree of self-esteem and embarrassment, particularly if a child is having issues with soiling in the school and a target of bullying, etc. But I'm wondering in terms of even longer term, in terms of a proportion of them who continue to struggle with incontinence into adolescent and young adulthood, what sort of complications or sort of, emotional sort of sequelae can you see?
Dr. Burke, would it be okay if I took the first stab at this? So we unfortunately do not have good long-term studies looking at the outcomes of individuals with childhood constipation onset and then their risk for and poor course and their risk for having trouble in adulthood. So that continuity between childhood constipation and trouble with constipation in adulthood is not clearly known. I would say that in my experience, longer duration of having a severe constipation problem and repeated impactions at a younger age and not intervening before early teenage years increases the risk for the colon not being able to recover with treatment and requiring longer term medication. So I have followed kids who've had like 8 years of impaction and tried to intervene with high dose medications, assuring that they're remaining cleaned out, but their ability to wean medication support has not, I've not been successful with that.
Dr.
Burke,
Bodankar, you had a question, sir? You can unmute and ask your question, sir.
Yeah, no. So sorry, it was wrong. But anyway, I have gone, Dr. Samir, Dr. Swati Bhave, and all they are doing wonderful job. I must compliment them on behalf of CIP and Command. The point about the developmental was taken very broadly and very up to the point. I have nothing to add except that it has to be very much user friendly, or you can say the parent friendly approach should be parent centric approach. That is what I might think. Rate all is okay. Thank you.
Thank you, sir. Yes. And I totally agree with that. There's so many times, physicians tend to dictate or preach to the parents who get very stressed out, who get very sort of overwhelmed with expectations, meeting them in a positive way, telling them they're doing a good job, telling them that this will be better, because it's a source of great pride when a child gets fully potty trained. And when a child does not reach that, sometimes the parents take it personally. They feel it reflects on them, on their competence, and really supporting them, as Dr. Burke and Dr. Felt had pointed out, is totally agreeable. I think, more so than the parents, I think pediatricians and physicians and other people need to take that awareness, because it's really easy to be a little hierarchical, do this, do that, right? Prescriptive knowledge. But sometimes stepping back and saying it's okay, there's no rush, you're doing a good job, then they leave with a sense of accomplishment. I agree with you, sir, completely. Yes, thank you.
Thank you. Thank you.
I wanted to add to that too. Sometimes it's so helpful to explain the changes in the gut that, like, truly this is no one's fault. It's not the parent's fault. It's not the child's fault. And we can work through this together as a team is like really important messaging too, to help alleviate the guilt from some of the parents or some of the self-blame from the kid is all like, there's really like a real medical thing going on here and there's a reason for this.
Yes, that
Highlight
demystification. Agreed. Go ahead. Yeah.
Just that there is a standard treatment guideline that I noticed from the Indian Academy of Pediatrics for constipation, as well as other elimination disorders, that it looks very up to date and is a good resource.
Yeah, IAP has almost 105 parental guidelines that published in 2022 regarding all the such type of the common problem related with the parenting. So they are the really excellent resource material for the everyone.
Dr. Samir, would you like to give any last comments?
Yes, sir. On behalf of the AACCI, I really sincerely thanks and gratitude to all the professors and the students of the Michigan University who are really coming and excellently presenting the approach for these things that will be mainly related with the international approach in collaboration with the in context with the Indian approach also. So it's really a great move that what at presently we are doing as a being an international forum of the AACCI. And my sincere thanks to Dr. Neil Soren for the taking a lead to get the such type of the faculty to come us and deliver such type of the important topic related lectures. So my sincere thanks to the whole team, and I sincerely looking forward to the next month also with such type of the interesting talk. Thanks a lot on behalf of the Association of the Child Care and Thank you, sir.
Thank you, everybody.
Yeah. Thank you, Samir. Thank you, Neil. Thank you.
Yeah.
It was a wonderful, informative, and inspirational discussion. Thanks a lot.
Thank you, sir. Take care.
Thank you.
Okay. Good night and good day to you all.